Allergic and immunologic diseases of oral cavity. So, what is meant by allergy? As we know, allergy is just a hypersensitive state, hypersensitive reaction to any specific material. So, this hypersensitive reaction, it may be of two types, either immediate reaction to on exposure to material or a delayed reaction. Immediate hypersensitivity reaction or immediate allergy. It is seen when circulating antibodies are present in the serum and the effects are immediate, like whatever side effects are there, they are just immediate. It is seen in cases of anaphylaxis, hay fever, and asthma. Whereas the delayed type of hypersensitivity reaction, the effects of side effects of reaction, they are manifested maybe after a few hours or few days on exposure to the specific material. Uh, Delayed hypersensitivity reaction is seen in cases of drug allergies. So the hypersensitivity is because of exposure to the material, and the circulating antibodies are not present in cases of drug allergy. They are manifested after the drug is ingested and after it is absorbed from the stomach. So it takes few hours for the side effects to manifest. So this is nothing but the allergic forms. So we'll see what are the allergic diseases of oral cavity. The commonest form which everybody or almost 90% of the population suffers from is the recurrent aphthous stomatitis or the recurrent aphthous ulcer. As we know, every one of us might have suffered from this ulcer at any point in our lifetime, either during the childhood, during growing years, or in adult form, either because of trauma to the area or any specific cause might. So ulcer is the term which everyone is familiar with because they have gone through this phenomena at one point in their lifetime. So what is recurrent aphthous stomatitis? These are nothing but occurrence of solitary or multiple painful lesions on the oral mucosa. They may be either single or they may be multiple. They are also known by common names like canker, so aphthae or aphthous ulcer. So what is the etiology for ulcer? The etiology for ulcer may be a bacterial infection. Few of the authors, they proposed a specific bacteria, that is a pleomorphic bacteria, Streptococcus sanguis. It has been isolated from many of the ulcers. So that's implicated in the etiology of recurrent aphthous ulcer. Along with that, immunologic abnormalities. Lehner proposed that recurrent aphthous ulcer, it occurs because of specific autoimmune response of the oral epithelium. Because of some irritation to the oral epithelium, the oral epithelium just develops antibodies, and that leads to development of this recurrent aphthous ulcer. So then few other authors propose that no, it is the autoimmune response, but it is not because of a central immunologic fault. That is, though there may not be any foreign substance entering, but the oral epithelium is just it's irritated, and it's leads to production of inflammatory mediators, antibodies, and production of the ulcer. So that's the immunologic abnormality. And many of the times, hormone related changes, like in premenstrual syndrome, lot of females show development of this recurrent aphthous ulcer. And the most commonest cause is the trauma, presence of a sharp tooth irritating, or a cheek bite, or a lip bite, biting of lips. Any specific cause just irritates the oral mucosa, and you see the development of a ulcer. And so we have seen the hormonal causes for ulcer, the bacterial causes, the genetic causes, and the immunologic abnormalities. All these they lead to the development of the recurrent aphthous ulcer. So recurrent aphthous ulcer have been classified into four major forms. There is the recurrent aphthous minor, recurrent aphthous major, recurrent herpetiform ulcers, and ulcers associated with a syndrome called the Behcet syndrome. So we'll see one by one what are the clinical presentations of them. Recurrent aphthous minor. Recurrent aphthous minor, these are nothing but the ulcers which we normally see on the lips or buccal mucosa or the labial mucosa, gingival mucosa, or the tongue or the palate. They are very like small. They are covered by fibropurulent membrane, and the ulcers, they are surrounded by an erythematous halo. If you can see the clinical picture there, so it's just the ulcer is about few to few centimeter in diameter, and it has been surrounded by a erythematous halo, and in the center you can just see a fibropurulent exudate is present, which is yellowish in color. So that's the presentation, typical presentation of an ulcer. Ulcer is nothing but a break in the continuity of the epithelium with inflammation, and this inflammation leads to production of the fibropurulent exudate. Okay. So recurrent aphthous minor ulcer, as I have already told you, females are more susceptible to ulcers because of endocrinal abnormalities like hormonal abnormalities or premenstrual syndrome. Recurrent aphthous minor is more commonly associated, and uh, it is a disease. Recurrent aphthous minors, it is seen in any age. I mean, it can be seen at 10 years, 20 years, 30 years, 40 years. At any age, you can just notice this recurrent aphthous minor disease. Prodromal symptoms will be present before the even the clinical onset of the ulcer. The patient may be suffering from a low-grade fever, generalized malaise, lymphadenopathy, and before the onset of ulcer, the area will just show inflammation. So it will be erythematous in nature. Then edema develops. Then it leads to development of ulcer. So these recurrent aphthous minor ulcer are very painful. Whenever an ulcer develops, you see the patient complains of excessive salivation and inability to eat the food, mastication, or he just, if the ulcer is on the lip, he just tends to keep the mouth open. So drooling of saliva also may be seen sometimes because it's like irritated in nature. So he finds it difficult to close the lips. If suppose in this case, if it's on the lips. So that's the clinical presentation of a recurrent aphthous minor ulcer. So recurrent aphthous major ulcer. Recurrent aphthous major ulcers are have the same presentation of ulcers as we have seen in recurrent aphthous minor, but they'll be like little bit larger in diameter, over 1 centimeter in diameter, and all of the ulcers, they may show the frequency of outbreak may vary. It may be from one attack per year or 2 attacks per year or 1 attack every month. In case of recurrent aphthous major, the patient will not be free from the disease, the recurrent aphthous ulcer, at any point in his lifetime. At one point, one or the other ulcer will definitely be present in his mouth. So these are very, very painful ulcer, more than the recurrent aphthous minors, because they are large in size also, and they are about 1 to 10 in number. Whereas recurrent aphthous minor may be a solitary ulcer, a single ulcer, or just 1 or 2 ulcers like that. Whereas recurrent aphthous major occur in groups of 10, and they heal. When they heal, they just leave like a scar like a thing on a oral mucosa. And because of the variation in frequency, recurrent aphthous, few of the sites may be healing, and few sites of oral mucosa, they show presentation of new ulcer. So this occurrence of recurrent aphthous major, it occurs in a continuous wave like a thing. So ultimately, when all the ulcers heal, the oral mucosa shows a great deal of scarring. And the presentation of recurrent aphthous major, clinically, the individual has a lot of pain, and he's having difficulty in mastication, chewing. The patient appears very irritated. And most commonly, clinically, the recurrent aphthous major have been seen after puberty, that is after about 12 years like that. And these ulcers, they persist for a decade like that. They persist for about 20 years or more. As I have told, the ulcers, few sites show the healing of ulcers, few sites show new outbreak of the ulcers. So at any given point of time, the patient might be having 1 or more ulcer in his oral cavity. So that's the clinical presentation of a recurrent aphthous major. You can just see the diameter of the ulcer. Yeah. And the same presentation of an erythematous halo with a fibropurulent exudatus present clinically. Then recurrent herpetiform ulcers. As the name suggests, recurrent herpetiform ulcers are nothing but the recurrent aphthous ulcer, which shows similarity with the herpes lesions. But the only difference is that when you culture the ulcer, you do not find any herpes virus here. So the name has been given recurrent herpetiform ulcer. As the name is recurrent, these ulcers, they tend to heal, and after few days again they start recurring. And the number of ulcers vary. They will be about 1 to 100 in number, whereas the recurrent aphthous major are 1 to 10, minor are just 1 in number. So recurrent herpetiform ulcers are about 100 in number, and the presentation is of a vesicle like a thing, pinpoint sized vesicles seen on the oral cavity, just resembling the herpetic lesions, herpes lesions. And but only difference is that herpes virus is not isolated from this ulcer, and they show more predilection for occurrence in females. So as I've already told, that recurrent aphthous ulcers, because of their endocrinal abnormality, because of the premenstrual syndrome, females are most commonly affected. These the herpetic lesions, as we have already seen, they are very painful, and they may persist for about 1 to 3 years before they heal, before they subsequently heal. So we have seen the presentation of recurrent aphthous minor, major, and recurrent herpetiform ulcers. Behcet syndrome, we'll see it separately because it's a syndrome in which you see recurrent aphthous ulcers. Okay, what is the histologic picture of any ulcer? As we know that ulcer is just a break in the continuity of the epithelium. Here also there is a break in the continuity of the epithelium, and you get to see colonies of microorganisms causing the ulcer. Bacterial etiology have been implicated. The Streptococcus sanguis is the causative organism, so that may be the finding here histologically. That is the presence of colony of microorganisms, break in the continuity of epithelium. Along with that, intense inflammatory cell infiltration is present. The inflammatory cells most commonly seen are nothing but the lymphocytes or the plasma cells. And there is epithelial proliferation at the margins of the cell, not seen in cases of all ulcers, but recurrent aphthous ulcer specifically shows the epithelial proliferation. And the microscopic picture of the ulcer is not specific in nature. So you have to correlate the microscopic picture with the clinical findings. Specifically, the clinical findings are very characteristic of ulcer. Just give the immediate diagnosis. Sometimes few of the authors have just Wood and his associates, they propose that a specific type of epithelial cell is seen which is characteristically associated with recurrent aphthous ulcer. That is nothing but epithelial cell. The nucleus is just elongated. It's rod like a thin, and it shows peripheral radiations of the nuclear membrane. That is the linear bar of chromatin along with radiating nuclear membrane is seen. That is nothing but the Annis-Chow cell. Annis-Chow cells are characteristic. We cannot say it is a characteristic of recurrent aphthous ulcer, but they are more commonly seen associated with recurrent aphthous ulcer. Behcet syndrome. As I have already told you, one of the finding of Behcet syndrome is a recurrent aphthous ulcer. It is also a disease of unknown etiology. It is a multisystemic chronic disorder of oral mucous membrane. It is showing a tetrad of symptoms, that is the presence of oral and genital ulcers, along with that cutaneous lesions and arthritis. So presentation of any two of the symptoms gives the diagnosis of Behcet syndrome. Along with the recurrent aphthous ulcer, oral or genital ulcer, along with the ulcer, you should have any of the one finding, either the arthritis or the cutaneous lesion. So Behcet syndrome, this is more commonly seen in cases of males. Males are affected more, and the age at presentation may be about 25 years to 40 years. Both the young and the middle-aged are affected. So how are the oral ulcers? The oral ulcers are nothing but the presentation of the recurrent aphthous minor ulcer. That is, the ulcers are very painful. They are just showing an erythematous halo with the fibrin prurient exudate in the center, and they are very painful to touch, and difficulty in swallowing and eating may be encountered by the patient. So that's about the oral lesion. Oral lesion may be seen at any site, like the lips, the buccal mucosa, labial mucosa, soft palate also, even the fauces, facial pillars, pharynx also show the presentation of this ulcer. So, and the genital ulcers, they are very, very small when compared to the oral ulcer, oral aphthous ulcers, and they are very small, seen on the scrotum or root of penis or labium major. So, this the presentation of the recurrent aphthous ulcer, the same like the recurrent aphthous minor or the recurrent aphthous major ulcer. They do not show any scarring like that. They heal within 7 to 14 days. And the cutaneous lesions are nothing but the lesions seen on the skin. They are initially manifested as an erythema or reddening of the skin. Or the erythema may be present, or the lesions may be papulosquamous in nature. That is, papule like a thing is seen. Papule is nothing but lesion, the lesion which is erythematous, and it is not raised above the surface, or if it is raised just 1 mm like that. And the presentation of erythema nodosum is common. This is nothing but the manifestation of Behcet syndrome. Then when we see the eye, when we see the ocular lesions, they initially begin with photophobia and irritation. There is sensitivity on exposure to light. So the disease begins with sensitivity on exposure to light, then it progresses to conjunctivitis, uveitis, and finally the hypopyon. So so it progresses from conjunctivitis to hypopyon. So the eyes, the skin, and the oral mucosa, these three triad or tetrad. Presentation of arthritis is also seen in case of Behcet syndrome. These 4 tetrad together constitute the Behcet syndrome. Out of these, at least 2 symptoms must be definitely present. Treatment for any ulcer may be a supportive treatment only. It is not a curative treatment, because the ulcer, it's like immune mediated function, and it heals on its own. Whatever treatment you are giving is just a supportive treatment. Either the mouthwash, tetracycline mouthwash, 250 milligram, which is given 4 times a day, or the application of topical antibiotic, or the application of hydrocortisone ointment. All these are just symptomatic, so that so as to make the area less painful, so that the patient is able to just take intake of food, and to make the disease less irritating to the patient. Supportive measures are taken. That's about the Behcet syndrome. Now we'll see the other common infectious disease of unknown etiology. That is nothing but the Reiter syndrome. Reiter syndrome, it is also a disease, chronic disease. It is of unknown etiology. This infectious disease, it occurs in male persons more commonly, and the clinical presentation is seen in cases of individuals about 20 to 30 years of age, and here it shows a tetrad of manifestations. That is, the clinical presentations definitely should show the presence of these 4 symptoms. That is the non-gonococcal urethritis, arthritis, conjunctivitis, and mucocutaneous lesions. So the presence of these 4 clinical symptoms give the diagnosis of Reiter syndrome. So how are the skin lesions? The skin lesions, as we can see in the clinical picture, it shows the presence of red or yellow keratotic macules or papules. Macules are raised above the surface. Papules are just flat lesions. So keratotic macules or plaques present on the skin lesion, present on the skin. Along with that, occurrence of arthritis. Arthritis is nothing but the inflammation of joints. So the patient has difficulty in walking, he has painful joints, he has swollen joints. And uh, this Reiter syndrome, it has been attributed the presence of urethritis. Urethral discharges are seen, so the area will be very painful. And coming to oral mucosa, you can see painless red, slightly elevated areas in the oral mucosa like a papule. Along with that, these papules are just surrounded by a circinate white color border. So beginning of the ulcer, we can see. Then the sites are more commonly the buccal mucosa, lips and gingiva, and on the palate, you can see hyperemic spots or petechiae, we can see. On the palate, you can see bright red petechiae spots are present. So that's about the clinical presentation of the Reiter syndrome. And when you see the histologic picture, you get to see the again the because of the erythema, you can see that inflammation is invariably present. Along with that, leukocyte infiltration is present, and the presence of the skin lesions, papules or plaques. So we can say that the clinical picture shows one of hyperplastic inflammation of the epithelium. There is parakeratosis, acanthosis, and polymorphonuclear leukocytes are seen because of the inflammation. So the clinical picture, the histologic picture give the diagnosis. Tetrad of manifestations compulsory are seen in the Reiter syndrome. Treatment is nothing but there is no curative treatment for this disease, Reiter syndrome. It just undergoes spontaneous remissions. The disease just resolves on its own. Just symptomatic treatment might have to be given, whatever antibiotics or anti-inflammatory in case of arthritis have to be suggested. Sarcoidosis also known as Boeck's sarcoidosis. It's actually disease which is having varied clinical presentations. It's more devastating to the oral mucosa, to the patient. It is a multi-system granulomatous disease. Normally, we have seen the granulomatous disease are like tuberculosis and all, but this sarcoidosis is also a granulomatous disease, and a variety of etiology have been attributed. Once the occurrence of bacterial infections, there is the immune dysregulated mechanism. There is some immunologic abnormality is present, thereby leading to production of inflammatory mediators which progress the disease, which leads to progression of disease. And the clinical presentation is more commonly seen in younger individuals and middle-aged adults. The clinical symptoms actually they are non-specific. So the disease is such of insidious onset that you may not know that the patient is suffering from the disease, because the clinical symptoms are also non-specific. Like the common presentation is the occurrence of malaise and cough. They do not give an indication of underlying destructive disease like that. So the presentation of nodules on skin, presentation of nodules on skin is the characteristic feature. These are nothing. Initially, they begin with erythema of the site. Then they progress to formation of nodules. In when we see in the oral mucosa also the lesions begin as nodules. They are like bleb-like or fist-like a thing, and they show a clear yellowish fluid or a solid nodule. Sarcoidosis, it is just characterized clinically by present of a discrete non-caseating granulomas, and mycobacterium and propionibacterium both are implicated in the etiology, right? So the clinical presentations are also the same, that is the appearance of granulomas. Even the oral cavity shows the presence of nodules. These nodules are like bleb-like lesions which show some yellowish fluid. So the sarcoidosis, it has been associated with the lymphadenopathy, hilar lymphadenopathy basically. It affects even the pulmonary system. So that's why it's a multi-system granulomatous disease. So here you can see the clinical manifestations of the sarcoidosis. It has been shown that skin lesions in the form of erythema nodosum are present. Along with that, you can see the lesions affecting the eye. Basically, initially it starts with the conjunctivitis, okay, and lymphadenopathy is invariably present, especially the hilar lymphadenopathy, and even the epithelioid granulomas are even seen in the lungs. So that's with the sarcoidosis. If you see the microscopic pictures, I've already told you, these sarcoidosis show granulomatous lesions, but they are non-caseating. So the caseating ones are the Mycobacterium tuberculosis ones. So the difference between the tuberculosis lesions and the sarcoidosis granulomatous lesions is that the sarcoidosis is non-caseating in origin, and it shows the presence of nests of epithelioid cells. Along with that, a multinucleated gained cell is present. Here, even in the clear histologic picture, you can see that's the appearance of a multinucleated gained cell. And when coming to the treatment for sarcoidosis, you have to give supportive therapy, that is, corticosteroid therapy has been very beneficial. Along with that, antibiotics are suggested for curing of this sarcoidosis. So basically, it's a bacterial infection. Then the uveoparotid fever. Uveoparotid fever, it's also a form of sarcoidosis only, but here, along with the granulomatous lesions, it is characterized by painless enlargement of the salivary glands. Most commonly the parotid glands. Along with the enlargement of salivary glands, you can see even the eyes are affected. There is enlargement of lacrimal glands also. There is inflammation of the uveal tracts of the eye. So uveoparotid fever is also known as uveoparotitis or Hereford syndrome. The name itself is giving that. There is inflammation or there is enlargement of the parotid gland. So along with that, it's also affecting the eye, as I said. So the eye lesions are characteristic in that initially they begin with just the inflammation of uveal tracts, then the conjunctivitis. This conjunctivitis, as the cornea just gets dried off continuously and the inflammation progresses, it progresses to keratitis, and finally corneal herpes lesions are seen. The treatment for the uveoparotid fever, it's also it is a form of sarcoidosis, right? Again, you'll see the proliferation of granulomatous lesions. Histologically, you can see that inflammation is present. Along with that, nests of epithelioid cells are present. And all the systemic manifestations, as we have seen in the sarcoidosis, that is the presence of a malaise, low-grade fever, cough, cutaneous lesions, all are present in the form of uveoparotid fever. Midline lethal granuloma. Midline lethal granuloma, it's a very serious infection. It's also known as a malignant granuloma or a lethal granuloma. It is a disease of very insidious onset, and it is very devastating to the individual itself, and the progression of the disease is such of insidious onset that even before the clinical symptoms show the side effects or the manifestations of devastating nature, the disease just keeps on progressing. Initially, the disease it was thought to be of it's actually a disease of unknown etiology, but some form of immune dysregulation is invariably present. So it was thought that some immunologic response is present, and that leads to progression of this disease. And the individual, the patient, he generally does not resist the progression of the disease. So his body is not resisting the progression of the disease. So the disease progresses very rapidly. So what are the clinical manifestations of the disease? Initially, the symptoms range from feeling of stuffiness of the nose, or some feeling of some discharge in the nose, or some stuffiness in the nose. This feeling of stuffiness, it may be present for months to few years. So the prodromal symptom, that is called. So it may be present for months or years, and then it progresses to presence of a superficial ulceration. So initially it begins with just the ulceration. The ulceration may be in the palate. Initially it begins in the palate, then it progresses towards the nose. So this progression, then it progresses rapidly, and it involves the cheek bones, the malar bones, the nasal bones. So ultimately, the soft tissue of the face, because of the ulceration, it just sloughs away. Eventually, there is necrosis occurring, and then there is destruction of bone also. And along with that, you can see the discharges from the nose and the eyes. There is brilliant discharges from the nose and eyes. So the clinical picture is necrotic lesion, blackish discoloration, and just the soft tissue slumps away. So you can just see the flesh on the face. There is nothing called epithelium. Eventually, the bone gets exposed to air, and the inflammation, which started from ulceration, it just progresses to necrosis, and it has systemic effects on all because of exposure of eye, that is uveitis or keratitis, may ultimately lead to vision impairment or blindness, and all sort of bacterial infections occurring. It affects all the systems, and eventually the patient, he just this disease terminates in death. What are the clinical? These are the clinical presentations. So that's why the term malignant lethal granuloma has been given. As the name suggests, it is a granulomatous infection. So the presence of histologically, the presence of extensive necrosis is seen. Along with that, inflammatory cells are seen. These inflammatory cells are all kind of inflammatory cells, polymononuclear leukocytes, plasma cells, and along with that, formation of new capillaries is seen. Treatment for this is just a supportive one. Because of the extensive soft tissue loss and the destruction of bone, eventually malignant lethal granuloma just leads to death of the patient. Because of involvement of the respiratory epithelium, it leads to, here in this malignant granuloma, the even the oral mucosa, the larynx, pharynx, and respiratory epithelium are also involved. So because of the involvement of respiratory epithelium, it leads in dysphagia or inability to breathe properly, and ultimately death has to result. Whatever treatment you are providing is just for the sustaining or reducing the progression of the disease. You cannot cure the disease, you can just reduce the symptoms, or just try to restrict the symptoms of the disease. Corticosteroid therapy is the only one which is proved beneficial. Wegener's granulomatosis, it is also a form of granulomatous infection. It is also a chronic infection of unknown etiology. Here, along with the cutaneous lesions, and the vascular system is involved, the renal system is involved, the respiratory system is involved. And here also the disease of affects the children of any age. It may progress from infants to elderly. It's also bacterial infection has been implicated, and pleuropneumonia like organisms, they are the most causatively causing this granulomatous infection. And initially the disease begins with inflammation, which is begins as rhinitis, sinusitis. Involvement of the paranasal sinuses is seen. Along with that, for eyes, otitis is seen, or the ocular disturbances are seen. Then the patient complains of generalized malaise, fever, cough, and hemoptysis are characteristic that this infection has progressed to the respiratory system. Fever, joint pain, and hemorrhagic or vesicular skin lesions. Skin lesions are nothing but erythematous lesions or vesicular eruptions on the skin surfaces. And involvement of kidney is characteristic that glomerulonephritis is seen. And when coming to the oral manifestations of this disease, lethal granuloma or the Wegener's granulomatosis, oral cavity, the gingiva shows extensive ulceration, hemorrhages are seen in the gingiva. Because of the ulceration, the epithelium of gingiva just sloughs away, and it is extremely reddened. The term strawberry gingivitis is used for it. Along with that, there is loss of alveolar bone, tooth become mobile, they are unable to just withstand the progression of inflammation. And once the tooth mobility occurs, the tooth are exfoliated from the oral cavity. And ulceration of the palate is also seen, as seen in the midline lethal granuloma. And the laboratory findings, They consistently show that almost all the body systems are affected by showing rise in erythrocyte sedimentation rate, anemia, leukocytosis, and the presence of hyperglobulinemia. And when you see the microscopic picture, it's one of a mixed inflammation. Along with the inflammation is particularly centered along the blood vessels. So the vascular system is involved and it leads to rapid spread of the infection. And because the respiratory system is involved, the patient has difficulty in breathing also. Treatment is again just a supportive one with a corticosteroid therapy. There is no curative treatment for this Wegener's granulomatosis, and it's an unknown etiology. Like that. Then we'll see the allergic. We have been seeing the allergic diseases affecting the oral cavity. As I already discussed, allergy means the term which indicates a hypersensitivity to any specific material or allergen. So we'll study the angioedema. Angioedema is also known as angioneurotic edema because along with the features of edema, you can see the patient has characteristic association of some neurological symptoms like confusion and all. So that's why the term angioneurotic edema has been implicated. Quincke's edema or gained urticaria. Urticaria, as we also know that it is nothing but allergic reaction to anything for which you are sensitive, for which the individual is sensitive. So angioedema, it is basically characterized by edematous swelling of the skin, the mucosa and the submucosal connective tissue. So what is the why edematous swelling is occurring? It's because of allergy. Allergy, how does it progress and why the allergy is occurring? It's because of antibodies are produced for an antigen. So that leads to production of inflammatory mediators, invariably leading to this clinical manifestations of swelling. So how the allergy, there are a variety of pathogens entering our body, that is the antigens which we are exposed to. The antigens may be either food substance to which we are allergic or a drug to which we are allergic. These leads to, they just go and bind to the mast cell. So mast cell degranulates, histamine releases, and Ig mediated hypersensitivity reaction occurs, thereby releasing of the inflammatory mediators. That leads to progression of this disease. Then sometimes angiotensin converting enzyme inhibitors are used by the patient to keep his cardiovascular system or renal system under control. So when the patient is on AC inhibitors, this drug, whatever drug, captropil or whatever is used, it leads to sensitivity to the patient. Sometimes it has been implicated with the sensitivity. Then activation of the complement pathway. As we know, during inflammation, progression of inflammation, a lot of pathways act to just lead to the progression of inflammation. One of that is the complement pathway. So activation of complement pathway, interleukins, either the interleukin inhibitor or the interleukin 1 or 2, they are just activated and leads to production of the inflammatory mediators, cytokines, and that leads to progression of disease. So what are the clinical presentations of angioedema? Most commonly, any individual of any age may be affected by this disease. They are manifested from children to the elderly. So clinical symptoms, when we see, most commonly the oral cavity and the eyes are affected characteristically. The lips show perioral swelling, that is the diffuse non-tender edematous swelling of the lips. Along with that, periorbital swelling, that is the eyes are very swollen, puffy, and because of the inflammation they appear red and swollen and they are just closed, that is the eyes are shut in the individual. And you can see in the clinical picture the lip is showing the edematous swelling. So lips, chin, eyes, tongue, and even the pharynx may be affected. Because of the inflammation, as we all know, the skin appears little bit red or pinkish in color, denoting the inflammation. So perioral edema, periorbital edema is characteristic of a angioedema or an allergic reaction. So whatever the etiologic agent is responsible for causing this, if you identify the etiologic agent and just remove it or withdraw it from your diet, withdraw the food from your diet, automatically the symptoms resolve. The symptoms of perioral or periorbital edema also resolve on its own after about 24 to 48 hours, or you can just administer antihistamines systemically, antihistaminic drugs, or sometimes epinephrine might have to be given intramuscularly. So that's about the angioedema. When you see that the individual has allergy to some of the drugs, then also you can see the cutaneous eruptions, characteristically the cutaneous eruptions. So that's nothing but the drug allergy. Stomatitis or dermatitis medicamentosa, as the name is indicating, both the oral cavity and the skin show the effects of drug allergy. So whenever the patient takes the drug, he manifests a delayed sensitivity reaction. That is, after the drug is ingested, it takes some few hours to absorb the drug. Once the drug is absorbed, the individual shows manifestations within a few hours. Initially, the erythema or the sensitivity reaction, it begins like a wheal and flare lesion, as we call it. Just the redness begins initially. So what happens, the IgE-mediated hypersensitivity reaction occurs whenever the drug is taken. So this IgE-mediated hypersensitivity reaction leads to degranulation of mast cells, release of histamines, again release of inflammatory mediators, cytokines, interleukins. They are responsible for the progression of disease. So what drugs are implicated? Any individual shows side effect to any form of drug. It's like few of them have been more commonly implicated in allergies. Those are nothing but the penicillin drug, the streptomycin, the aspirin, chloramphenicol, and the tetracycline. So as I have already told, the wheal and flare lesions begin initially. That is, the cutaneous eruptions or the vesicular eruptions begin. So the cutaneous eruptions are the first symptom seen. Then they begin with presence of fever, low-grade fever, then lymphadenopathy, that is the lymph glands show enlargement, and leukocyte count may be decreased, or leukopenia or neutropenia is seen. That is nothing but the agranulocytosis. So how are the skin lesions? The skin lesions are erythematous and papular lesions, as we have as we'll see in the diseases like erythema multiforme or exfoliative dermatitis. That is, the papule, whatever is formed, it just desquamates and just tends to peel off from the epithelial surface. So, and fixed drug eruptions are also seen. Fixed drug eruptions are nothing but scaling of the epithelium from the surface of lesion. And when you come to oral cavity, if the oral cavity has been in contact with the drug, like in chewable drugs, it's most commonly seen the contact dermatitis, as we call, contact stomatitis as we call. So whenever the drug is placed in oral mucosa, it's in contact with the oral mucosa, and that particular region, it shows the characteristic lesion. So in oral cavity, we get to see ulceration. Initially, it begins with inflammation, it progresses to ulceration, and finally necrosis and hemorrhage is seen. So gingiva shows inflammation, it becomes red in color, gingival hyperplasia is seen, and altered taste sensation is seen. The salivary glands show hypofunction. So that's the thing. And when you see the microscopic picture, the epithelium, it shows presence of sometimes when ulceration is there, there is a break in the continuity of epithelium, proliferation of epithelial cells is seen, along with that subacute mucositis, that is inflammation with a mixture of lymphocytes, eosinophils, and neutrophils is seen. The treatment for this contact stomatitis is withdrawal of the drug if identified at the earliest, and injection of antihistaminic drugs either systemically or intravenously. Then cortisone, in severe cases corticosteroids are given so to provide the symptomatic relief. So the causative agent, if identified and if it is just removed from your intake, then you'll never get to see these symptoms. And the other thing is, once the individual has been sensitized by getting these symptoms, on second exposure to the same drug, the whatever symptoms we are seeing, they are just aggravated more, because and the lesions are seen at a very earlier pace. So it just take few minutes to see the lesions the second time when the individual is exposed to the same drug. So because already antibodies are present and you're just giving the same drug, they just act up very fast like that. So that's about the dermatitis medicamentosa. Medicamentosa is nothing but ingestion of drug orally. Here contact stomatitis is nothing but the whatever drug or substance is there. Either suppose in dentistry we use a lot of materials in oral cavity, which may be hypersensitive, for which the patient may be hypersensitive. Either the mouthwashes or the therapeutic rinses or the solutions which we are using to irrigate the oral mucosa, or the endodontic materials whatever we are using, or the restorative materials whatever we are using, or the acrylic or the rubber based materials which we may use, or the latex gloves which we may use in the oral cavity. We use a lot of restorative materials, so the individual may be sensitive to one. Either the most commonly is the denture based material, the acrylic denture based material. The patient may also be sensitive to acrylic denture based material. He may not know it, and it's the first time that you are placing the acrylic in the oral cavity. So acrylic denture based material, they commonly manifest this form of stomatitis and dermatitis. That is the contact stomatitis. Contact stomatitis occurs at a localized rate. That is, the lesions or the symptoms are seen only in the place where the foreign material has been kept. Like as in case of denture base, only the place where the denture base is kept manifests the clinical symptoms. So initially it begins with the itching or burning sensation, then erythema occurs, then this inflammation progresses to ulceration, vesicle formation, and finally erosion. So the mucosa also, if oral mucosa has been affected, as I've already told, the denture base or the acrylic material is the commonest, or sometimes even the rubber dam material, that also acts as a foreign material to few of the patients. So the mucosa becomes remarkably inflamed, edematous. Whenever the mucosa is becoming inflamed and edematous, it becomes red in color and becomes shiny and smooth in appearance. Severe burning sensation, itching, tingling, and edema is reported. So the microscopic pictures of stomatitis, as I already showed, shows presence of inflammation along with edema. This edema makes the cells appear swollen in nature, and presence of vesicles, that is vesicle formation, is seen. Both intercellular and intracellular edema occurs, that is edema occurs between the cells and between the epithelium and basement membrane, that is nothing but the showing the vesicle formation. And because of the inflammation, the blood vessels are dilated, they are engorged, and any inflammation, it is associated with presence of lymphocytes and plasma cells, because they are the markers of inflammation or the mediators of the inflammation. And as I have already told, dental restorative materials or drugs or flavoring agents or mouth rinses, whatever we are using, they manifest a form of contact stomatitis, that's also known as lichenoid reaction. In oral mucosa, it appears, the lesions show whitish in color, they appear whitish in color, papule-like lesions resembling lichen planus. They may be reticular, erythematous, erosive lesions with a white streak. So that's why they resemble lichen planus lesions. And treatment for this is identifying the causative restorative material or the acrylic denture based material, whatever is causing this lesions, it just have to be removed from the oral cavity, and symptomatic relief has to be provided by applying topical antibiotic or topical hydrocortisone. The symptoms just resolve within a few days. So that's about the allergic and immunologic diseases. affecting the oral cavity. Immunologic diseases, as we have seen, they all are like immune mediated or immune dysregulation. Some form of autoimmunity or immune dysregulation is occurring, that's leading to progression of the disease. So these are the allergic and immunologic diseases of oral cavity.